So the one question that I have for the panel, because it doesn't have anybody necessarily designated, it says, are all patients treated in the field with Narcan transported on to the emergency department? And if not, why?
There are two levels of treatment now. So there is family or relative or friend given Narcan. A lot, and I don't have the data, but a lot of folks being picked up by JFRD have already had Narcan on board. Once we get the pilot going, we'll have that data a little more clearly. Now, once JFRD has them, then they do transport them to the emergency department. And more Narcan is usually needed in order to stabilize them. And I would say at that point, 99, if not 100%, leave the ED and go back and use.
Would there be one resource that you would like people to investigate more or look into, or something that might be a little bit of passion for you? I can say the one last thing that I would say is that if we, I believe if we want to change, one of the problems that we're having, and I think it's the underlying problem that a lot of times we don't talk about, and Faces and Voices does all the time, is the stigma around this disease that we still have. And I see a lot of people nodding right now. And this disease, even though we absolutely know that it changes brain chemistry, that it is a brain disease, has not really, the education has not really gotten out there maybe like we are hoping to lay people. I talk to lay people all the time, and they really don't have any idea about what do you mean by brain disease? Or isn't that just an excuse, or those kind of things. When we have, look up National Institute on Drug Abuse. They have some wonderful information there about the brain and how it changes brain chemistry and brain wiring. And so around that, the other thing that we know is language can be stigmatizing or it can be empowering. And because the recovery community has used words like, and I'm in long-term recovery, by the way, so because the recovering community has used words like addict and alcoholic in order to help identify and break down our own denial in terms of being able to be in recovery, that those words have come out into the public, and now most people use the words addict, alcoholic, and yet they carry an awful lot of baggage. And so how do we change that language? How do we use words that really talk about what this is, which is a clinical condition? It's a clinical condition. So anyway, that would be my thing. And now I'd like to start with Dr. Palm and ask him.
All right. Recovery is important. Everything we're doing is important. We got to get over ourselves. I'm just going to say that, because even in the recovery community, there's stigma. Okay. We've got a problem here. We cannot look to the government for all of our help. We can look to the government for more problems, but we can't look to them for our help. The help has to come from the community. This has to be a grassroots effort. Some examples: hospitals, emergency departments, businesses, all have to come together and help with this problem. The AA-NA 12-step community has to become more accepting of people on medication-assisted treatment. They have to open the doors. We can't do what has always been done: segment, fractionalize, the problems and the solutions. The solutions have to be as a one solution for the entire community, with the entire community. I don't have one resource to give you, but I got one idea, and that's what I just said. And whatever role you can play with that idea, now's the time, because we're dying. We're dying rapidly.
Thank you.
I don't know what to say after that. That's awesome. I agree with everything he said. So, but I will say there are pretty good resources out if you want to have more education, in particular about medication-assisted treatments. The federal government does actually do a pretty good job At SAMHSA has some excellent resources that are available. Have a whole webpage about buprenorphine. You can learn about it. It has patient handouts. Got a lot of good material there. I don't want to forget, we're here to talk about opioids, but still, you know, the number one cause in addictions for morbidity and mortality remains tobacco, and then alcohol a close second. So we don't want to lose sight of the other addictive disorders that are out there. The National Institutes on Alcohol Abuse and Alcoholism have excellent resources for clinicians to help people deal with people who are drinking too much. We got to maintain our focus on the other addictive disorders. It's hard for me because in our field, 90% of my practice right now is medication-assisted treatment for opioid use disorders, but there are other addictive illnesses out there that we need to keep in sight. Great resources are present there. We mentioned NIDA already has some good stuff. And the nice thing about the resources in regards to if anybody's doing therapy, CBT for substance use, or handouts for patients for alcoholism or reducing problem drinking, you know, that's all bought and paid for. There's no copyright stuff. You can have it mailed to you. You can download it. It's all free of charge on there, and they're excellent resources that are publicly available. And with that, I'll pass it on.
I would probably say we can't feel like they're pariahs. You know, oftentimes when I'm sitting in the ED and you'll see the stereotype language come across when they're giving report and passing report on to, you know, team member to team member. And just the other day, I was with a patient and I came out and you could hear the team members talking, and I said, "Do you realize this person is a professionally trained opera singer?" That completely changed their perspective on the patient. And, you know, I know I was touching on it earlier, but we all fall down and we can't continue to pass judgment on these people because it is such a powerful drug and it literally just takes them over. Now, will they be completely clean and sober for the rest of their lives? I don't know. Maybe, maybe not. But even if they do fall, we can't pass judgment. We just have to say, what can we do to help you this time? I think one of the things that I often see too is the families will, you know, they often have no peer support, no family support. The social support is extremely lacking. And that's probably something that I would focus on a lot is when you're working with these folks that have these strong addictions, are there any bridges that they haven't burned? Are there any that we can mend with a couple of 2x4s, at least just something? You know, oftentimes it often circles around money. And, well, I've given them money for this, that, and they've stolen and they've done this. What can you give them? You know, if it challenge your families to do that, what can you give them? You don't have to give them love. I mean, you have to give them love. Check. All right, it's 8:30. But yeah, I think that's probably you know, go back. Don't ever lose the compassionate side of why we're here to take care of the patients.
All right, so something was touched on earlier. Because I work with adolescents, primarily the drugs I worry about, to me, are the ones that really are the ones that if we could figure out a way to get rid of those, most of the drug problem will go away, in my opinion. What I worry about is Adderall and Xanax. That's what's killing my patients and my clients. Now, one thing that scares me really bad is that prescription medication is not prescribed to the user. That category is outpacing, hasn't caught up yet anywhere near, but it's outpacing marijuana use. That's a very scary thing for a person like me. And so what I worry about most is that. I worry about, you know, the fact that I got kids that love, that you know, eat Xanax like it's M&Ms, Adderall, they pass it around like it's, you know, nothing. But if there was one thing I could talk about too, would be the same thing. What we need is capacity. The thing that we always end up, in my opinion, I've been doing this a long time. I'm on the board at Gateway. I'm on the board at the Northeast Florida Council of Alcoholism and Drug Abuse. I'm really, really involved in this. And we always end up with where are we going to put them? Always. Every single time. Where are we going to put them? We need capacity. So the one thing I would champion would be that, is beds, and beds especially for females, young and old, but especially female beds. There's an unbelievable shortage in that. So that's my thing. Thanks.
Thank you so much.
I think one of the things that I'm just real fast, one of the things we didn't touch on, and I saw his slide, is what are we going to do with the next generation that's being born addicted to these drugs? And I didn't have the data to show you guys as far as what's being presented in our NICUs, but that would probably be an additional topic for a future discussion.
Okay, I want to thank you so much, and I want to thank you all for staying those last few minutes. And can we give our esteemed panel another hand? Excellent information, given us so much to think about. So thank you all. This concludes our program. Please have a good evening. Drive safely home. Thank you.